Good evening and welcome. If you're joining us here in person, it is Monday night, 7 p.m., and this is the CARES program. Monday nights is very special in the CARES program because this is a night where we bring in expert speakers that speak on addiction and recovery, specifically support for the members and friends who have been touched by addiction. And if this is your first time here, we'd like to welcome you. We also want to let you know that addiction is a big thing in our country, with 1 in 4 people touched by addiction one way or another. Our program represents communities and relatives empowered for support. And we do that by providing education to our community, resources, and the opportunity to connect with people that can provide answers to questions of what do we do next when it comes to our loved one. So thank you for supporting us, those of you who are online and also here in person. And I'm very happy to welcome a good friend of ours, Daniel Sledge, who is, and I'm going to go through this wonderful experience as Daniel Sledge is a active member in the community. He is a licensed EMT. He's also been a supervisor with the fire department. He stands on 2 federal committees dealing with substance abuse treatment. And he has a very special presentation for us and a conversation on opioid addiction, overdose, and what we as friends and family members should know and could do to help individuals. So with that, let's welcome him with a warm applause. Thank you, Daniel, for joining us. And Daniel, I want to kick off with just a quick question here off the bat. You know, there's a lot of people out there that say we have heard about alcohol addiction and we're aware of it. We have heard about meth addiction and all these things, but you have a lot of people who are saying we hear buzzwords like the opioid crisis. And for some people, this is sometimes the first time they hear about this. So what would you share with someone who's saying, I don't know much about what's happening in that area?
Yeah, that's a good question. Thanks, Renee. First I would say that number one, there's a difference between substance use and substance use disorder. So if we take the thing that we're probably most used to, which would be alcohol, not everybody who drinks has a disordered use of alcohol. So just remember that things are on a spectrum. If somebody does wind up on the end of the spectrum where there's disordered use, it's a medical condition, and the good news is that it's very, very treatable, especially for opioid use disorder. There are 3 medication options that are FDA approved and work very, very well at reducing risk of overdose and risk of death. And so I think pointing people, getting people connected to, evidence-based treatments, things like that are crucial to helping those that we love.
And Daniel, you say that there's medications to help out in this space. For those people who, hearing about opioids, I mean, there may be a lot of people out there that say, well, this wouldn't happen in my family, or I don't know if that's something that applies to me. How prevalent of an issue is this?
It's prevalent, and the other thing is that it addiction doesn't know any sort of subgroups of demographics or anything. It transcends all of that, right? So, if we think in our head like, well, this side of the railroad tracks doesn't, or this part of town, or this, or my family, and this and that, it's like addiction doesn't care about any of that stuff. And so, which is to say that these shouldn't be shameful conversations. Again, this is something that happens and lives inside the brain. It's a condition that's highly treatable. And so I think that, let's see, to answer your question, I will go on tangents. Just so, you gotta reel me back in.
I love it. That's a creative space where we brainstorm. So
yeah. So yeah, I would say it's not the Hollywood idea or picture that you may have of like, the person kind of laying face down in a gutter. It's substance use disorder or addiction transcends all sort of demographic boundaries or whatever. So it would be uncommon if somebody said, I am not touched by addiction at some point, at some level of, friend, family, or loved one.
So, addiction, as you said, and we've had many speakers on the stage that share that same exact message, that there is shame that families feel in coming forward and saying that addiction is in my family. And yet, everyone is saying the same thing, which is no, it's common, it's happening. We need to break past a lot of those barriers to have hard conversations, but to also be more informed. So, when you think about opioid, addiction and crisis, what are key things that people in the community, family members, parents, siblings, are not hearing enough? What should they know about opioid addiction?
Well, number one, when I worked on the post overdose follow up team, we did a lot of post overdose follow ups with folks who had a non fatal overdose. And a large portion of uh, the ones who had these non fatal overdoses did not have addiction. They didn't meet diagnostic criteria for an addiction, even mild. Um, and what when we talk to them, like, hey, I'm glad you're okay. Tell me about what happened and stuff. They'll say like, hey, well, I was kicking back. It's my birthday weekend. I just got a job. I was celebrating, and I had half a Xanax and a few beers or something like that. In normal cases, right? Like back in, like kind of old, but like back in my day when you had half a Xanax, it was half of a Xanax, half of like, a 1 milligram of alprazolam or whatever. But now, if you're getting pills that are from not the pharmacy, so from the street market, I promise you that they're pressed. They're counterfeit pills, and they're made to look exactly like pills that you would get at a pharmacy. But instead of 2 milligrams of alprazolam, it just we don't know what's in them. A lot of times it is fentanyl, and possibly some other research chemicals and stuff like that, benzos. But the the issue with fentanyl, when it's added to a pill, it's not measured the same way that we measure things in a pharmacy type situation, like a lab. We're not using high precision instrumentation, to measure fentanyl like we measure it when we're, making a product that, we carry on the ambulance. When I worked on the ambulance, we carried fentanyl as a painkiller, so if if I fell off this stage and broke my arm or something like that, then I would get fentanyl as a pain reliever while, they're packaging me up and stuff. It's really, really potent, though. We measure it in micrograms, okay? Which, when you're getting it in the vial, like that's fine. We can dose it, accurately. But when you're adding it into like a pressed pill, it's more kind of like this. And so there's not as much margin for error when you're talking about very little mass between a dose and an overdose. Maybe a handful of grains of salt or something is the difference between a dose and an overdose. And so I think that's all the big tangent to come back around to. It takes awareness. That's what I would say to families or students or adolescents or anything like that. It's like, hey, if you get a pill not from the pharmacy, then it's pressed. I promise you, it's pressed. It's counterfeit. It's made to look like it's the stamp. It's going to match the imprints of something. It's going to be color matched. It's going to look really good. It may look like, oh, that's a 30 milligram oxycodone, but that's not what's in there. Right?
So what you've shared here is that you know the pressed pills that people are taking, it's a painkiller, but the balance of it and how it's mixed is unpredictable. So when you're talking about the possibility of a fatal overdose just even from the first time trying something, is that
Right. Exactly. Yeah. Thank you for kind of bringing me back around. It's that we need to have this awareness, and because some of these patients that I interacted with who had overdosed, they weren't they didn't have addiction or anything like that. They were experimenting a little bit with substances. But because of the drug supply and the way it currently is right now, that led to a near fatal overdose in some of those cases. And so I think having that awareness, and I work in this field, and so I'm like, well, everybody's got to know that by now that's what the pills are and stuff. That's not the case, you know, and especially with kind of like that adolescent, middle school, high school ages and stuff. We just got to get that awareness out, and not like fear factor, kind of like,
Mhm.
you know, like you're gonna die if you look at drugs or something. But just giving people accurate information so they can make informed decisions. Like, you know, because people, including myself, don't respond to like, you know, just the finger wagging, like, what is it? Drugs are bad, MK, you know, like from South Park or whatever. But like that that doesn't work. You know, we got to give accurate information.
And you were talking about, the different age ranges. And my mind was thinking, when you talked about, the drugs that people take that are outside the pharmacy, they're getting this in different places. You work with UT Pharmacy, School of Pharmacy. You've got a program, Teach OUD, and your focus is on bringing that awareness. But my mind was thinking, okay, well, college. That makes sense. I hear stories, people out there at that age, but you said middle school and high school.
Hmm.
So talk to us more about how prevalent is it there in those spaces?
I mean, we did follow up on some patients who were 16, 15. And I think that once you get to that age, the drugs they're there. And so if we set kids up for success by saying like, hey man, this is, you know, there's going to be stuff out there, because if we give them the information first, so like, hey, I want you to know what you're walking into, that's way better than them just getting introduced to it for the first time outside of,
Mm.
you know, us telling the kids at home, you know. The other thing too with even before middle school is just making sure that that your kids have a safe place, a soft place to land,
Mm.
so that they can come to you and say, "Hey, I've been doing X, Y, Z, or whatever, and I think I need some help." Because if you make it hostile, or if they don't feel safe, then they're not going to disclose some of these things that might be kind of difficult, you know. So I think really setting that stage with "I love you no matter what," you know.
Yeah, that's a good point. As part of what we do here is we try to offer resources, we try to offer education, but also practical tools that families can use. And you brought up something very important, which is just building that safety within a family so that they can have these conversations. And I like how you framed it because you said even before middle school that you can start having these conversations so that when they come up or an issue comes up, that they can feel connected, they know where to go to talk about these things. If you're talking about something that, and my mind keeps going to painkiller, how would someone know that someone's ingested an opioid? What symptoms would you look for? And whether it's a parent, a teacher, someone in the community, how would they know that this is what's happening?
So if you're asking about like signs and symptoms of overdose,
Hmm.
maybe then the big one is breathing poorly, and that's what we looked for when I worked on the ambulance. That's the main thing, and that's the thing that can that makes overdose dangerous. Is that it turns down our our signals to breathe. And so what it ends up looking like is somebody that you can't really wake them up, and they're breathing poorly, and they may have skin signs of low oxygen. Um,
Mm.
and so regardless of how melanated the skin is, it's going to have a dusky tone, you know, bluish, dusky, grayish tone. And then for darker skin, we can look at places like the palms and you know, under the eye, um, cheek, gum, those kinds of things. But those would be signs, pale, bluish, grayish, skin tones that say, hey, this person's not oxygenated enough. So you may see that. Um, but, if the breathing is slow or irregular or absent, it's time to do something.
And, I think of symptoms like that and immediately I think 911,
Hmm.
right? And so that seems like an appropriate course of action to call an ambulance, call a medical expert like yourself to come in. Uh, is there something else we do in the meantime? Or, what are we talking about in terms of timeline to respond?
So it needs to be quick. It's very time dependent. The same way that you know, um, if somebody's heart stops, we need to get CPR and an AED on them pretty quickly. And so we want to. One of the big pushes is to train lay folks, non-healthcare providers, how to use naloxone and how to respond to an overdose, and essentially provide that first line of treatment before EMS arrives on scene. Um, and or go ahead.
Oh no, I was going to say that's big because, when we talk about CPR, anyone who's gone through CPR training, there is this fear of, well, what's going to happen when the moment happens? Will I remember all of this? Some people who might be just even scared to train in that space. Same thing for using a defibrillator. And what you're saying is that just like CPR and a defibrillator, um, being trained on how to respond to an opioid overdose is something that should be readily accessible to everyone and just normal. How hard is it for someone to be trained on how to respond?
It's really easy. And I think, oh man, what was it? Maybe I'll get a fact check or something, but I think it was 2018 when the Surgeon General released an advisory that said, hey, everybody should carry naloxone and know how to use it. Because at that point, that's when overdoses were to the point where they were so pervasive that it's like we need to add this to our toolkit for lay people,
Hmm.
because these overdoses are so common. But if we can intervene quickly, then that can be a difference. Somebody walking out, having all their faculties and everything, somebody surviving without any deficits.
Well, a whole purpose of CARES program is to provide that space where we provide that information. Families who are saying, this may not apply to me right now, but a couple months down the line, they might remember a conversation like this and say, I remember when we were talking about overdose. I remember when we were talking about what to do or how important it is to react or how easily it is to help save someone
Mhm.
in that moment. Um, so, is there anything that we need to know about how this looks or where we would be able to get this kind of training?
So too, there's a lot of different places. I have on there's the one slide with the QR code on it. I don't know if we could pull that up, but it goes to a video, and it's my favorite video of how to respond to an overdose. It's like 4 minutes long or something like it's not that long. And if you bookmark that on your phone, and then you can uh, show it to loved ones or anything like that later on, watch it, get a little refresher. But it's one of the reasons it's my favorite is because it's not just about getting the medicine on board, but it's also about giving rescue breaths. So it
Mhm.
goes through both of those things, and both of those are paramount to a good response.
Right. So we have the QR code up on screen here. For those who are watching online, this is something you can scan. Those in person, I already see people are starting to scan this. So this is working. You're bringing awareness. You're also providing resources here. And we'll have this floating in the videos here moving forward. Um, and I'm going to bring us back here for a quick second here. Um, when, I mean, visuals, there's the training, 4-minute training that we can go to, but can families get some of these resources, have that ready? Where should they keep it?
Yeah. So the best place to keep it, I'll answer
Hmm.
that one first. The best place to keep naloxone is wherever you're going to have it on you so that you can respond to an overdose. So people sometimes ask me, Daniel, can I keep it in my car? What about the temperature and that kind of stuff? The most important thing is access.
Mm,
Yeah, it degrades a tiny bit with like super high temperatures, but it's not that part's not super important because it still works very well even
okay.
after exposure to high temperature. The main thing is access. So if you're out and about, are you going to have it with you?
Mm,
So I keep it in my pocket. I keep it, I keep one in the car too, but I don't ever want to be, where I've walked 17 blocks or whatever from the car. And then I'm like, oh, this is the one time I needed to have it with me.
So I'm going to ask a question that I'm sure maybe some people have on mind. Uh, what if I make a mistake and this person is not having an opioid overdose and I administer something like this?
Good question, Renee. I'm glad you asked that. Naloxone is so safe that if you are wrong in your diagnosis, it has no effect.
Wow.
So basically, what it does is, if you have an opioid tied to a receptor, and once it latches onto that receptor, it does the effect of the opioid. And if you have enough of those opioids on receptors, you could get from a dose to an overdose. And let's say like the person stops breathing. All right. If you bring naloxone on board, what that naloxone does is it will kick off the opioid from the receptor because it binds with a higher affinity.
Mm.
So it's like, oh, get out of my chair. So it kicks off the opioid and then it attaches to that opioid receptor and it does nothing. So what it's
Wow.
done is it's basically pried that opioid drug off of the receptor and got it off. And then now it's sitting there basically saying like, you can't occupy this receptor site. You can't kick me off. I'm king of the hill or whatever. I don't know. And so it does nothing. It has no effect. So then you've brought that person from an overdose out of an overdose. Now, let's say that I don't know, let's say we all work on the same ambulance together and we go to a call and it's unknown, unknown call, like unknown man down or whatever at the bus stop. And there's nobody there to give us information or anything like that. Nobody there to give us a history. And we find somebody who is slumped over and breathing poorly. Well, we can't ask any question. Like, we just got to start doing some testing and doing some diagnostics, doing some, getting vitals, looking at signs. And if we see somebody who's unresponsive and they're breathing slow, let's say maybe there's paraphernalia, there's a needle cap near at the bus stop. And I say, Renee, this could be a fentanyl overdose. Let's drop the naloxone. And we give it, but let's say that unbeknownst to us, this is an overdose on, we'll say, alcohol and Valium, okay? Valium, a benzodiazepine, two things that are also depressants that if you take enough of those, they will slow your breathing down and they will make you not responsive. So it looks identical at this point. We don't know that though. So we're like, hey, this could be an opioid overdose. So then what happens is we give the naloxone and it's going to come on board and it will find the opioid receptor and it will it doesn't have to kick anything off though. There's no opioid, there's nothing on it. So it will just attach there and it will, occupy that space. You can't sit here and it does absolutely nothing. So then all we would see is like, well, there's no effect, And sometimes we would give it in as kind of a diagnostic tool. Is this an opioid? It could be, but it's one of those things where it can't hurt. It might help.
Okay. And walk me through. I mean, we talk about naloxone, but is that a syringe? Do I need to, inject someone with it? What does this look like?
Good question. So there are different formulations or preparations of naloxone. The old school one, which is very, very effective, is a syringe. It's a you can have a syringe and a needle, and then you draw it out of this one of these flip top vials. and then give it like a shot in the shoulder or the leg or something like that. And it's very safe and effective. And it's very inexpensive when it comes in this preparation.
And you said this is the old school?
That's the OG right there.
Okay.
Yeah. And what you'll find in many public places, schools, airports, things like that have like a lot of places are adding naloxone to the AED cabinet. And so what you'll probably encounter there is the nasal kind. Basically this nozzle goes in the nose, and then you press this button down here and it shoots a fine mist into the nostril, and then that's it. There's no more doses left in here. So it's just like it's a meter dose, and it makes a mist. I have a show and tell visual aid one. So basically this the manufacturer for this type of naloxone says it's 3 P's. Peel, which is like peel it open. It was funny because I was like, that's like, duh, of course you're gonna peel it open. Place is to place the nozzle into the nose, not next to it or kind of under it or anything like that, but place it into the nostril, just like Afrin, and then press. And then you'll press this button right down here, and let's see if this works. Yeah, there it is. That's just water, by the way, just in case you're on pain meds. But that's all it is. And then this will be absorbed into the nasal mucosa. So it doesn't matter that if they're not breathing. This will be absorbed into the bloodstream that way. There's no needle. And they made this product essentially to be so simple that a person could pick it up and figure it out on the spot. Obviously, it's preferable if we have some training so that it's not the first time you're seeing it isn't in a medical emergency, but that's how user friendly it is.
So this program exists within a church community. It was built out because this is a space where people were curious and they wanted to learn more about addiction, about resources, about how to support family members. There are many communities like this out there. Do the regular CPR training. If you're working with children, you go through background checks, and you have to be trained with CPR and know how to handle devices, the AEDs. For something like this, you mentioned schools are using this now. Do all schools have them? Should they have them?
It's mandated that I think at least high schools in Texas have it in the first aid kit.
They have this now in schools already.
Right.
Okay.
Yeah.
Okay.
And there's instances, I mean, how many summers ago there was a cluster of overdoses in Hayes County in high school age kids. And they were, it's not common like all the time, but there are instances where there have been overdoses at a school or while the person's on campus. And you need that medicine, you need it now, the same way you have minutes, to get that intervention on board, whether it's the naloxone or CPR and AED. And the same thing with, if you've seen, the schools have to have the stop the bleed kit and everything like that. So same thing with tourniquets or anything or any bleeding intervention, it's got to go on quickly. So that's why it's, we want the lay public to be the first responders, because that's who has the potential to do the most help, make the biggest difference.
When you first brought out the needle, I was terrified. So I'm like, unlike yourself, you're a licensed EMT, you have experience, you've gone in these spaces, but I'm not trained in that space. And I think a lot of families are very hesitant, but you've shown us a demonstration of how easy it could be applied. It almost looks the same as like the allergy medicines that people would take. And it's something that would literally save someone's life if it ever came down to it. You've also talked about how this is already as state law in schools right now. And again, the hope being that you would never have to use it, but it's comforting to know that it is there if it ever needs to be used. What's your recommendation for organizations, communities, churches, um, spaces where people gather on a regular basis? Um, they need to keep at least one, two, and where do they go to get this to be part of their um, part of the plan of action if someone needs it?
I would say, okay, where to get it? We'll start with the
Yeah.
second part first because it's top of the mind. Um, it's since 2023, it's over the counter, so you can go get it, HEB, whatever, any of these big box pharmacies and stuff. They run about 40-ish, $43 or something like that. That's if you just want to buy it as an item and not go through insurance. Most insurances will cover it. Most are at a like a no copay. Some are at a low
Wow.
copay, and there are standing orders. So you can go to the pharmacy window and say, "I would like to purchase naloxone under the standing order," and have it go through my insurance. You can also go to things like naloxone Texas dot. I think it's org. I should have researched it. But they will mail you naloxone, and they'll mail you more than one dose. So, depending on whether you're an individual or an agency or organization, they can mail you a case.
Yeah.
So for faith-based communities, I would say there's two prongs. Number one is to have it in a first aid kit like situation so that if there were an incident, you know, nearby or in the parking lot or whatever, you can respond. Number two, the other prong would be distribution. So that somebody, comes to the church and says, "Hey, man, my cousin is getting released from Travis County today, and he's got a history of substance use. I'm super worried, and stuff. Where can I get this medicine?" If you have some on site, you can say, "Here, right here. Do you want some on the spot training? We'll watch the video together. I'll give you some resources and stuff like that." And you don't want that to be the same dose as the first aid kit dose. You want to have that's your emergency response, and then you also have some for distribution. That
And
makes
what's the
sense.
difference?
Because if you distribute it to that dude who's like, "Hey, I really need this, dose. My cousin's getting out of jail or whatever." You're like, "Here, man, take that." Well, then later on, if somebody has an overdose, you're like, "Oh man, we gave the naloxone away,
Okay.
or else we would totally be using it right now, but we just gave it away." So, if you have your emergency, your go bag, or your first aid kit, and then your distribution.
And how long do they last? Expiration?
So another good question. FDA says, was it 24 months? Some of the products are 36 months expiry from data manufacturer. However, there are all these studies that show that even after a 30 years expiration, the medication is still good,
Wow.
and it's still good at a level of this will easily reverse an overdose. So we tell people don't throw expired medication away. Just because it's expired doesn't mean it won't work. That's just basically what they have to do. They have to put that on the label. And it will work. It doesn't degrade into anything harmful. So if it expires, it's not like potato salad or something where, "Oh man, it's expired, don't eat it,"
Yeah.
so doesn't degrade anything harmful. And it will still work. So don't throw it away.
Okay. Well, we're going to open up the conversation here in just a minute here for anyone that has questions. And if this is your first time here with us in person or online, what you're witnessing is our Monday night sessions where we have experts that come in and share information and topics that are relevant to families and friends of those struggling with addiction. We want to bring awareness, as we've done here today, but we also want to open up space for questions because we know many people will have lots of questions on this topic. And so while a microphone starts making its way around, so if you have a question, raise your hand. We'll have a microphone going on around. I wanted to ask you one last question, which is stigma. and how maybe there could be family members out there, people who are very cautious, very nervous. Will I do the right thing? Or also even fear about, is this actually a true risk? If I'm not seeing any signs in my family that, my kids are using or on a path where I should be concerned, I might not want to look into this direction. So, what do you say to those people who might have all sorts of feelings around this?
Yeah, man. These are all good questions, Renee. The thing about stigma is that it keeps people in silence and it keeps people in the dark, and when we, and in my family, there are things that you just don't talk about,
Mhm.
and because that's how it's always been. You go up generations. You don't talk about mental illness and stuff, and we don't talk about addiction and stuff. These are things that are upsetting, and you just, kind of. That doesn't make those things go away. It makes the person who's living through that feel so unsafe that they don't have someone to bring it up with. And if they think like, man, I think I'm going through something, whether it's, mental illness or whatever it may be, any of these stigmatized things, then you're basically training people to shut up and to stay
Mhm.
quiet about it. So but what's cool is that the inverse is true. So when we open up and we say we can talk about anything, and I have a 10-year-old, and I want to just impress this in him because sometimes I get a little anxious because through my genetics is a strong, addiction history of addiction, myself included, and I want him to know that it's safe to come to me to talk about anything, and I want to impress upon him all the time, like, hey man, we love you no matter what, you
Mhm.
know, and I think if the church can, that's somewhere that a church can really kind of make or break somebody's experience. I was raised in the church, and I think in some aspects, when it comes to not judging people, we have some room for improvement. There's
Mhm.
always room for improvement there. And so if we can say, like, hey, this is a safe place, you are loved no matter what, anybody's welcome, lay your burdens down, all this kind of stuff. To say like, whatever you got, bring it, and let's unpack it, right?
And you've brought us full circle to something that you started off at the beginning, talking about addressing shame, talking about making it safe, that families can create that. And you're also saying that communities can foster that as well,
Hmm.
a safety and being able to have conversations, to be able to learn together, to be able to support each other, be prepared as well, hoping that, this isn't the case, that we ever have to use it, but knowing that it is available, the training is there, and there's an understanding. Um, I know I said last question, but well, I'll save this one for the very end. So if anyone has questions here, we've got a microphone going around. Please just raise your hand, and we'll pass that microphone around to you.
Thank you for sharing with us tonight. Sadly, I have lost a couple of family members in their 30s,
I'm sorry.
and I'm pretty sure they didn't know it was fentanyl in there. I'm thinking it was, Xanax or whatever. But how do they? How do you get off that stuff safely? Like, what are the methods to get off? And is it something you can cut cold turkey, or how do you try to get them help?
That's a good question. And first, I'm sorry for your loss. The there are So there's three medications that are FDA approved to treat opioid use disorder. Two of them are linked with huge benefits. They're methadone and buprenorphine, and there's some stigma about the medications themselves. I don't know what's on the screen, like, yeah. So the other one is extended release injectable naltrexone. But if you go to the next slide that has the two circles, there we go. So for methadone and buprenorphine, being on those sort of, it reduces overdose risk by 70% and reduces any cause of death by 50%. And there's very few things in medicine with that kind of mortality benefit. Basically, what they do is that fentanyl is pretty short acting, and it's very potent too. And so your day, when in terms of dose, looks like this, right? And so what methadone does, for example, it activates those receptors similarly. It fully activates them, but it looks like this. The dose curve looks like that, and so it stabilizes that, so that you don't have that kind of roller coaster cycling of a dose and then pretty quickly going into withdrawal and just on that cycle all the time. And then it's actually overdose protective through cross tolerance. So if somebody were stabilized on methadone and they used fentanyl, even by accident, they're protected because they have a high tolerance to opioids because of the methadone. It also takes the reward out of using. So if you think about, let's say, if each of the opioid receptors were like a dimmer switch, and the methadone turned the dimmer from 0 to 100. So you have all these dimmer switches that are at 100, and the person is stabilized on methadone, and they say, hey, let's use fentanyl this weekend. And they use fentanyl. Well, the fentanyl normally would come in and turn all the lights on, but since that person is stabilized on methadone, the lights are already on. So when the fentanyl comes on board, it doesn't really have that much of an effect. That rush, that big whoosh, isn't there. And so that's called diminishing return. And so that you kind of take that reward out. The other one, buprenorphine, the brand name is Suboxone, and that's a partial agonist. And so it doesn't activate that dimmer switch to 100, it goes to like 60. But it binds to that receptor stronger than fentanyl does. So if you have somebody who is stabilized on buprenorphine and they're like, oh man, like Renee, oh, it's my job, dude, let's go, one for old time's sake, and they use fentanyl, then anywhere that already has a Suboxone, the fentanyl can't attach there, if that makes sense. So it has fewer landing spots. So it's overdose protective as well. These are things that are consistent with the evidence, and this isn't to say that other modalities aren't valid as well, because people use drugs for various reasons, right? The drugs are, to the person, they are a lot of times relieving symptoms of something else, right? So whether it's psychiatric illness or trauma or chronic pain, any of these things. So if you get somebody stabilized on one of these medications, then you can start doing the work to, whether it's trauma therapy or figuring out some of the chronic pain stuff, or getting the mental health on kind of situated better. You start to build some stability. And there's no rush to get off of those medications. We used to give Suboxone as like a 5-day taper or something when someone got into detox. The evidence says like, hey, we weren't doing that right. We now should, at minimum, 12 to 18 months, keep somebody on it before we fiddle with the dose any. We want to see those signs of stabilization. So then the person says like, hey man, I've been on this and been a year and a half, and I'm doing, I've got all these supports built up around me. And then we can start talking about reducing the dose. But in terms of risk benefit, these medicines they're awesome. Did that answer your question, hopefully?
And we've got time for additional questions. So if you have a question, please feel free to raise your hand. Got another one?
So Thanks for all your comments. This is really interesting. So, for the parents that are listening tonight, I mean, I'm kind of curious what your experience has been at how prevalent this is with young people today, because you hear about the epidemic, but I'm assuming that, you take a lot of trips to high schools or college campuses now, and just maybe, if you could give us some idea on how widespread this is a problem for young people.
It's prevalent, and that one of the populations that we did most of the follow-ups with was young people, emerging adults, and adolescents as well. And this is, if you think about it, this is an age where people are trying drugs, they're trying different substances. The thing that's different though is that the drugs that they are trying aren't what they say that they are. So when we were growing up, we're like, well, I've had a Xanax. I know what it feels like. I took half a Xanax from my Mima's medicine cabinet or whatever. That was a real Xanax. And so when I take another one, I have an expected effect of what it's supposed to be like, right? The same if you have, an ounce and a half shot of bourbon or whatever, there's an expected effect because you're like, well, that's an 80 proof, liquor. I know what it should be what it says on the bottle. The issue is that now the market is saturated with these counterfeit pills. So I think just raising awareness, being like, hey man, you've got to know. And that's the one thing that I really try and hammer home if I'm talking to a school is like, y'all have to know that this, and even if your homie's like, man, these are legit, I promise you, like, they're not. If you didn't get it from a pharmacy, they're just not, okay? You've got to approach it like universal precautions. Like when we started wearing gloves on all medical encounters, I'm not saying that this person has HIV, but I'm wearing gloves for everybody anytime that I might come into contact with blood. Same thing, like these universal precautions should have, it's like, it's a little analogy there. So I just want to get that message and that awareness out there because there's more and more students who are aware of that. There's fentanyl awareness as part of school curricula now. But still, there's people who either don't know that or they've heard kind of BS information from like YouTube or TikTok or whatever. They're just hearing stuff that's like not even close to accurate. And so if we can be trusted sources of information and trusted sources of confidence, that they can confide in, then that puts them way ahead.
So, Daniel, I'm hearing you share right now that this is very prevalent with adolescents, young adults. We're at that stage developmentally where they want to experiment, they want to form an identity. There is the old phrase, right, of peer pressure. So this is an at-risk group that we're trying to reach out to. Schools are now prepared by state mandates to have something to respond in these moments. And it just makes me think, is there some place that we would share with families if you wanted to learn more about this? Is there a website? Is there a resource that you recommend for anyone who wants to study more on this?
Yes. Can I get back to you on that?
Yeah.
And we put it as like a link or something
Yeah,
like
we
that?
can absolutely do that. I'm also thinking about your efforts in terms of this program, Teach OUD. And you're going locally here in Travis County. You're sharing information about opioid use disorder and really connecting with people. Could we go on that website? Would there be resources that we would find there?
Absolutely. A lot of those resources they're patient facing and they're provider facing. And we talk a lot with providers and say like, hey, Dr. Renee, it's very important that you treat this population and here are the treatments that are, evidence-based and not just medications, but also other interventions that are evidence-based. So like linking somebody up to peer support and these other things. And by the way, here's a list of sites in Austin that you can refer somebody to because you're a busy provider. So it's like, how can we reduce your administrative burden? And just you can say, hey, here's some places to go for these different things. peer support, medication, things like that.
Perfect. And we're going to add that as a resource here. One of the things that we want to do on our website is to continue to build an active resource list so that if a parent does have a question, whether it's about alcohol, whether it's about opioid use, that they know this is what the experts are recommending. This is where we can go for next steps. So this has been incredibly helpful and insightful. I want to open the floor. If there's one more question, I want to make sure if anyone has one last question, we can open it up. Good. Going once, going twice. All right. So what we're going to do too at this point is just remind people that we are online, social media presence on Facebook, Instagram, LinkedIn, and YouTube. So for those of you online and also in person, if this has been helpful for you, we encourage you to go ahead and subscribe on the social media pages, forward, really connect with this. We're trying to bring awareness in the Lakeway community, but also beyond, because these are things that, and I'll admit, there was a lot that I learned. It was hearing it through you for the first time that I heard that there was a state mandate on this being a part of schools, and that just woke me up to the fact that schools are taking this seriously, and there's so much that we have to learn. So they wouldn't make a mandate like that lightly in schools. So it's helpful for us to know as a community how we can be proactive. So Daniel, thank you for joining us tonight. For those online, again, stick with us. For those in person, we're going to hang out for just a little bit here. If you have a question you want to personally ask Daniel, he'll be around and available. Just a reminder, we are weekly. So we have speakers lined up all the way through the end of May. If this was a benefit to you, please feel free to join us. Next Monday, we'll have Drew Dutton, who is a familiar face to our presence, third time presenting with us from Phoenix House in Dallas, and he'll be talking about brain science. So you don't want to miss that. That'll be 7 p.m. every Monday night that we have speakers all through May. And last thing we'll say, if this is your first time here, welcome home. You've come to a right place in a safe space. So we hope you'll consider joining us next Monday. And again, Daniel, once again, thank you so much for coming out.
Thank y'all.